Hey everybody, I am just reflecting on the day that I've had and realised that a topic that I haven't spoken much about is the use of nasal sprays that are steroids, particularly in the context of trying to help children breathe. Now, it's an interesting topic as far as my sad little world goes, in terms of what I consider interesting, because when we look at nasal sprays, we're talking about steroids. Now, these are anti-inflammatory steroids, so these are designed to settle down inflammation. And when it comes to inflammation, we can get a little bit caught up and mixed up in terms of differentiating between local inflammation versus systemic or body-wide inflammation. And we can also get caught out with looking at what are the initiating events and what are the consequences. So when it comes to the use of nasal steroid sprays, there's been a lot of interest with this in respect to kids that can't breathe properly, as to whether they will help shrink down things like the tonsils and the adenoids. And there was some initial research that was saying, hey, this works really well, this is great. When that research was then collated and reviewed subsequently, it turned out that the results weren't as good as we could have hoped or wished for. And in fact, what has also come out with the research, if we look at how these steroids work, so on the surface tissue lining, there are little receptors that the steroids need to bind to for the steroids to do what they do. And what that found in the tonsil tissue, for example, is the amount of receptors that would recognize the steroids was actually decreased. So that infers that you would need a lot of steroids to bring things down. The situation in that context then is that should we be using steroids if we don't think that they work? And it's a dilemma of sorts, because if a child can't breathe properly at night, then the alternative is surgery, which also, as I say to parents, is, sometimes I have to give you a rock and a hard place in terms of making these choices and decisions. So let's weigh them up. So nasal steroid sprays, as the name infers, a steroid. It's a medication. It does have some known side effects. The one in particular is blood noses, as a well-recognised side effect of the medication. And a lesser known, but certainly a side effect that I've seen at times, is irritation of the throat. And then lesser again, but again what I've seen is that for some children it actually alters their mental state. They can start having behavioural problems, abnormal behaviour patterns, as a result of the steroids basically mucking their brain. So not common, but a scenario of sorts. And you have to be on it for weeks and to be honest, months, and sometimes you need to sort of say, look, do you want to be on the spray to help you breathe for the rest of your life? So what's the alternative? Surgery. So there's different types of surgery, and the surgery really is tailored towards the problem. And when it comes to, for example, if it's just adenoid surgery, look, that's a very quick day surgery procedure. It's not much time that they're under an anaesthetic, and it's not, generally speaking, that involved in terms of recovery, just a bit of analgesia and so forth. There's no problems with eating or drinking and so forth. If we ramp that up to tonsils, though, look, there is certainly some downsides there. They take a little bit longer, obviously, to do as a surgical procedure. The recovery is substantially more significant in terms of the pain that's experienced and the compromise that has with regards to eating and drinking, and also risk of bleeding that can put them back into hospital and need surgery again. So these are all real-world scenarios that we need to weigh up. But the outcomes and the benefits and the effects also need to be put into that equation. And the reality is, when we look at steroids versus surgery, we get far more reliable and far better results when we look at surgery for tonsils and adenoids than we do when we look at steroids. But for those that want to try, it's reasonable, but in that context, that child needs to be followed up again by the same ENT that's making that decision, because you need to make sure that it worked. And I think in 15 to 20 years, I've seen less than 5 sets of tonsils get better with steroids. So I obviously personally don't really think that it has much to offer based on those outcomes. Where it's a little bit more interesting is when it comes to nasal allergies. Now, with nasal allergies, they get swelling and congestion within the nose, and that is a localized inflammation, which is different to the tonsil and adenoid inflammation, which seems to tie in with associated systemic issues. With the allergies, something gets into the nose and it causes a local tissue reaction that causes swelling. You get the steroids into that area, and it does seem to have quite a marked effect, especially with the allergy symptoms like itchy, sneezy, runny nose type things. And in fact, the nasal steroid sprays are the first line treatment for nasal allergies. Pretty much 90% plus of people that I see have been reaching for the antihistamine medications. Antihistamine medications are, okay, but they don't work as well as the steroids do. In fact, the treatment algorithm is that you're supposed to use the nasal sprays first, then use the antihistamines as a top-up. But most people don't do that, but just so you know. Then when it comes to kids that can't breathe properly, then, look, yeah, I certainly use lots of these nasal steroid sprays. And I start them off it usually takes about 6 weeks if it's going to make a difference. So I usually see them about 2 to 3 months afterwards to review their progress, see if it's helping. And there's basically 3 outcomes of sorts. One is it's a complete waste of time, okay? In that scenario, at least we tried. We'll do some surgery to get them breathing properly. Scenario number 2 is that it was an overwhelming success. The allergy symptoms have cleared up, the breathing has cleared up, everything looks fantastic. And the third scenario is it's somewhere in between those two. And in that in that third scenario, I'll just let them go for a bit longer and say, look, we're making progress, it's not as good as we want. They may just need more time. We'll give them more time and see what happens. But when it comes to the ones where it works, it's kind of actually a little bit tricky, because it's great that it's worked, but how long do we keep them on them? So what I then do is, if they've had a great response and looking really good, I say, all right, we know that if we use this all the time, we get a good response. We can't be on this forever. This is not a lifelong treatment. I personally don't like the kids being on these medications for much longer than about 6 months or so. So then we start to wean it, and rather than just stop it, we just drop it down slowly, and we see what happens. And if they start to relapse, then I sort of look and say, look, this was just a Band-Aid therapy. It bought us some time, but it really hasn't achieved the outcomes. But if they can use just a little bit now and then that's great. They can use a little bit now and then for years, as far as I'm concerned, without real concerns about some of the side effects and so forth that I mentioned. The other thing that then gets thrown into the mix, obviously, is working out, if it's an allergy, what they're allergic to, trying to reduce their exposure to it, and then implementing a treatment that's called immunotherapy, or desensitization is another terminology that's out there. And basically it's a therapy to try and get kids used to what they're allergic to. And it works really well depending on what the allergy is and how many allergies there are. But it's a program that takes 3 and sometimes as long as 5 years. That's too long to leave a child that can't breathe properly. So when I approached the allergy side of things, I basically break it up into the breathing and the everything else. And if they can settle down with medication with all of the above, great, no problems, over to the allergy doctors and do the rest. If with their breathing side of things, we don't get a response that's adequate, or they're needing lots of medication to achieve that and we can't maintain that dose forever, then I'll operate. And when I operate, it's not with the intention of curing the allergies, it's purely to get their breathing sorted. And then sometimes for those kids where the breathing's better, they've still got the allergy symptoms, we get the nasal sprays into the system, which then settles things down and keeps things under control. And because their breathing is sorted, which is, of course, my reason d'entrée for being here, then the allergy doctors can then sort out the rest with the itchy nose and the sneezing and so forth. But I've got them breathing, which I think is the crucial element to get sorted. So long story short, nasal steroids do have a role. I don't find that they're particularly useful for tonsils and adenoids. I do find they're particularly useful for nasal problems, but I also do find myself operating rather significantly with kids that have problems with their noses to get them breathing better. In fact, if I look at what's going on, I've noticed two things. The first thing is nasal turbinates, are the swellings inside the nose that I'm talking about that are affected by allergy. The surgery that I do for nasal turbinates has now become the #1 operation that I do in children. It's surpassed adenoids, it's surpassed tonsils. People talk about taking tonsils and adenoids out, and obviously I do that. But turbinate surgery is way, way, way ahead of things in terms of numbers in kids. So that's the first thing that I've noticed. The second thing that I've noticed, if I go back and look at what I was doing, say, 15 years ago, and looking at what sort of turbinate surgery I was doing and what sort of age group I was doing it in, I'm starting to do operations in 4-year-olds. And in fact, recently I did one in a 2-year-old. But I'm doing surgery in much younger age groups than I was doing 15 years ago. 15 years ago, there might have been 7, 8, 9, 10-year-olds. Now I'm doing 4, 5, 6-year-old levels, where their allergies are just so bad and they're so blocked that we've got to get them breathing, and this is the only way that I find is reliable. There are other sort of surgical approaches there, so you might hear about something called nasal cautery or turbinate cautery. I do use it. I use it in the little kids, but I do so explaining to the parents that the research and the science, and this is my experience, is that it doesn't work very well, and it certainly doesn't work for very long. And usually within about 6 to 12 months, the problem's back again, and we're going to have to do something else. But for some kids, when they're so little and space is a problem, that may be the only thing we can do. And then there's what's called radiofrequency ablation, which is basically a shrinkage technique. The nasal turbinates are swellings inside the nose, made of soft tissue and bone. When we use the radiofrequency, then we're shrinking the soft tissue down, and that does open up the space, and I do find that works quite well. And then probably around about 2 years or so is when things start to go adrift again. But that's a pretty good time that we've bought. The turbinate reduction surgery otherwise involves removing the excess tissue build-up and also removing part of the bone of the turbinate. So a bit of a long-winded one for you all to take on board, but I just thought it, again, may be helpful just to sort of try and put this information out there so people can start to understand and rationalise things, because we know that as medical people, as scientists, we don't do a good job of conveying what we know to the general public, and I hope that things like this help bridge that gap. Thanks. Bye.